Test 1 1, test 1 1.
grateful for the privilege of serving JPS. Let us be grateful for every single team member who works with us, and grateful especially for every patient and for all the communities we serve. And as we begin another fiscal year, we ask for your wisdom to guide us, your courage to equip us, your compassion to fill us as we do all that you are calling us to do. In your holy name we pray. Amen.
Please stand for the pledge.
For which it stands, one nation, under God, indivisible, with liberty and justice for all.
Thank you. Well, I am proud to introduce to the board members as well as to the entire JPS family a new board member who is replacing Dr. Chuck Weber. Dr. Margaret Holland is joining us. She is a physician with Baylor Scott and White in Fort Worth, but hails as a resident of JPS, our own residency program from July 2013 to the present. She is a licensed attorney as well as a licensed physician, and we are welcome and grateful for your service. We hope that it is as pleasurable as our service has been and not as painful. So, so if you'd like to come up here or there or wherever, and we'll do a quick oath of office. Do I need to sign this? I'll take this with me. All right, if you'll raise your right hand and repeat after me. I, Margaret Holland.
I, Margaret Holland.
Do solemnly swear or affirm.
Do solemnly swear or affirm.
That I will faithfully execute the duties of.
That I will solemnly execute the duties of.
Member, Tarrant County Hospital District Board of Managers.
Member, Tarrant County Hospital District Board of Managers.
Of the state of Texas, and will to the best of my ability.
Of the state of Texas, and will to the best of my ability.
Preserve, protect, and defend the Constitution and laws of the United States.
Preserve, protect, and defend the Constitution and laws of the United States.
And of this state, so help me God.
And of the state, so help me God.
Congratulations. Welcome to the team. All right, we'll be sure to get her on 4 committees, and there's a really exciting meeting every Friday at 11:30. So we'll be sure to get you tuned in, involved real quickly. So welcome again. Okay, it is clear we have some citizens wishing to address the board, and we're always happy for that. I will say today that it appears that everybody is from the same group or for the same issue, and I've got 3 people that are wishing to address the board. Is there one person who is able and willing to speak as the spokesperson for the entire group?
The answer is no. We have 3 speakers. This is a public meeting in a public hospital. We want to speak. Well,
this is, you're obviously here to speak about the McDonald's. It is not an item on our agenda. Technically, we don't have to allow that public hearing because it's not an agendized item. And so if you would like to speak, I'm willing to give a speaker for the group 3 minutes to present your concerns, accept your written comments, and I can get that distributed to all the board members, and then give instructions on how to get on a future board agenda to speak whatever case you would like to.
It's not clear that we had to apply to get an agenda item. I doubt we would be able to do so. We want all 3 of our speakers to speak, or we're going to have an answer to a First Amendment issue.
Okay, then I'll tell you what, I'll give each speaker 3 minutes and no more than 3 minutes.
Thank you. Thank you.
Dr. Anna, I'm sorry, it's not, I have this here. Anna Herbie?
Yes. Hello.
We'll put the clock up and you can see the time for yourself.
Good afternoon. My name is Anna Herbie, and I'm currently living in Spring Branch, Texas. I'm a dietitian and diabetes educator, and I hold a doctorate in health sciences with a focus on nutrition. Until recently, I worked with patients of all ages at Howard Memorial Hospital in Willits, California. And currently, I'm the Nutrition Education Program Manager at the nonprofit Physicians Committee for Responsible Medicine. In my work as a dietitian, I've seen firsthand how an affordable plant-based diet made up of fruits, vegetables, beans, and whole grains can help patients with diabetes lower blood sugar, maintain a healthy weight, and reduce risk factors for heart disease. For the most part, these healthy foods are not available at fast food restaurants, like the McDonald's in JPS Hospital. After a quick visit to the hospital this morning, I was pleased to see signs in the cafeteria for Meatless Mondays and a few plant-based options on the daily menu. However, the cafeteria is in the basement and it's only open during certain hours throughout the day, while the McDonald's is open all day and it's the first thing visitors see, or one of the first things they see when they walk in. The McDonald's menu is dominated by cheeseburgers, chicken nuggets, and other foods that are high in saturated fat and lacking in fiber. These foods can put you at risk for insulin resistance, cardiovascular disease, and other serious health problems. A survey published in the peer-reviewed journal Pediatrics found that hospital visitors perceive McDonald's food as healthier than it actually is when it's located inside a hospital. When these unhealthy fast foods are so readily available in a healthcare setting, we risk sending the wrong message to patients about nutrition, along with visitors and staff who are in the hospital. The authors of the pediatrics paper caution that the presence of a fast food restaurant in a hospital could work against the advice of the hospital's own staff dietitians. And as a dietitian who has worked in a hospital, I would advise JPS to improve its food environment and provide nutrient-dense, disease-fighting, plant-based options instead of the McDonald's meals. Thank you so much for your attention to this important issue.
Thank you. Dr. Rizwan Bukhari.
May I remove my mask to talk?
Please.
Thank you. All right, thank you very much. My name is Rizwan Bukhari. I'm a vascular surgeon from the Dallas area. Some of you may remember me. I spoke at the June meeting, and I want to thank you for allowing me to speak again. I'm a whole food plant-based vascular surgeon. That means I eat whole food plant-based as a lifestyle, and I don't eat meat and processed foods. I limit the oil that I intake. And the reason I became this is because of what I do as a profession. I've seen the ravaging effects of a poor diet on my patients. And when I became whole food plant-based, it actually reinvigorated my spirit as a healer, because I found an opportunity to teach my patients how not to get disease. 80% of the chronic disease we treat today, 80% of the disease that JPS treats is chronic disease caused by lifestyle. So in 2020, JPS was named a best hospital in the United States. It's a highly respected healthcare institution, and the local community looks towards JPS for guidance for healthcare. They come here to get taken care of, and I think they look at JPS as a steward for healthcare. I think it's important that JPS changes its food environment and not have the appearance of supporting and recommending unhealthy, artery-clogging foods like cheeseburgers, French fries, and chicken nuggets. It's well established in the scientific literature with hundreds, if not thousands, of published studies that show that high-fat and low-fiber foods are linked to heart disease, impaired insulin metabolism, and even cancer. Ironically, it's often the socioeconomically disadvantaged populations that are served by safety net hospitals like JPS. And yet these are the people who have the highest rates of diabetes. Diabetes today is 80 to 90% diet related. When I was a surgery resident doing rotations at Parkland back in the 80s and 90s, there was a McDonald's there. And McDonald's was also a safety net hospital. At the time, I thought nothing of it because I didn't understand the connection between nutrition and health. But as our understanding of disease has changed and evolved and improved, things have changed too. The McDonald's has gone from Parkland. The McDonald's has also gone from Grady Hospital in Atlanta. It's also gone from Ben Taub in Houston. Okay. I think it's time for us to seriously consider getting it out of JPS as well. I don't think it's if it's going to happen. I think it's a matter of when it's going to happen. And I believe that you guys, respectfully, as board members, are stewards of this hospital and this community, and it's your responsibility to do the right thing. Thank you very much for your time.
Thank you, Dr. John Pippin.
Thank you for the opportunity for us to speak. I'm Dr. John Pippin, local cardiologist, Director of Academic Affairs for the Physicians Committee for Responsible Medicine. The community organization you see here attended the June Board of Managers meeting to urge John Peter Smith Hospital to disengage from fast food restaurants. There has been no response, so we're here again. We just had an informational demonstration outside, and we're here to reinforce our argument. Particularly concerning is the diet-related surge of diabetes, obesity, hypertension, high cholesterol, and premature cardiovascular disease in children and young adults, which as a pediatrician, Dr. Duncan well understands. The New York Times reported just last week that, quote, 1 in 7 American adults has type 2 diabetes, up from 1 in 20 in the 1970s. Many teenagers are developing what was once considered to be a disease of older people, unquote. A report from Health Promotion Perspectives concludes that a review of relevant research, quote, provides further evidence warning us against the irreparable effects of fast food consumption on public health. A report from top cardiovascular journal Circulation describes the association of fast foods with heart disease deaths in more than 52,000 adults. A single fast food meal per week increased the risk of cardiac death by 20%. 2 to 3 meals increased it by 50%. 4 or more increased it by 80%. An accompanying editorial from the Harvard School of Public Health reinforced these conclusions. These few referenced articles are the tip of an iceberg documenting beyond contention the many and chronic harms of fast foods. Why is this in JPS Hospital? Establishing the proposed JPS food pharmacy to combat poor dietary choices while facilitating the same poor choices in the hospital seems nuts, like bailing out of a bathtub without turning off the water. All the safety net to hospitals noted by Dr. Bukhari, except JPS, have ended contracts with fast food hospitals. Why is JPS an outlier? Look, it's not complicated. Promoting and profiting from fast food restaurants in an institution dedicated to disease prevention and treatment is an abomination. Again, we are here urging JPS to disengage from fast food restaurants and to inform your community of your plans. Thank you for your attention, and we will now leave and let you carry on your meeting.
Thank you all for your attendance. We have your written comments as well, each one of us, and we appreciate your time.
I did just want to clear up for the board an earlier comment that was made. We are not in any way impeding anyone's First Amendment rights. Those were allowed outside of the building. The conduct of the board meeting is governed by the Texas Government Code, and so we do kindly ask, the board was very generous in allowing the comments to go forward, but we will ask that you comply with our policies next time. Thank you.
All right, with that, we'll move for approval of the minutes from our September 8th board meeting. I believe those were attached in the portal as well, and we have all the information. Are there any corrections or notations to make? I'll seek a motion to approve.
Move approval.
I've got Reverend Emerson and Steve. Cool Steve or Dr. Steve? Which Steve? The one that thinks he's cool. I got Steve. No, I got Steve that's on vacation and Dr. Steve. So.
I think he's cool, Steve.
All right. With a motion and a second, I'll ask all in favor say aye. Aye. Any opposed? Motion passes. As far as board chair report, I don't really have anything because I didn't know that I was going to be sitting here other than to ask for thoughts and prayers for Ms. Debose and her family. She was sad to miss the meeting today. I will just, a word that comes to mind whenever I, either driving or whatever, thinking about this hospital, this district, our employees, and our patients is resiliency. And if you think about all the different areas, not just healthcare related and pandemic and whatever else related, but it's construction and it's taxes and it's politics and it's everything. And resiliency is a good word that always comes to mind. So I'm really proud of not just our staff and our partners, our patients, but also of this board. We each have a specialty to offer and in different areas where we specialize in, and that makes a very nice melody as a very good working board. So I appreciate each one of y'all for your time and attention and patience with us. Dr. Duncan?
Thank you, Chair Fisher. And I echo what Roger just said. Amen to that. As everyone's hearing, it looks as if we may be entering into what's called a twindemic. That means that there's probably going to be both COVID and both flu in our communities, and we as a hospital will probably be faced with a lot of that coming through our ED and through and into our hospital. With that said, I want to say that we are offering out in the community to our staff and even to you, board members, the COVID-19 booster and also the flu vaccine. And so I would encourage everyone to get that. As far as other updates that are going on, we continue to be out in the community, doing a lot of work out in the community, especially as schools started back. Many of you were here when Zelia spoke on the mental health consortium program that helps identify mental health issues in our children and in our schools, and just want to update you that they continue to expand into the school ISD, so that's great. The Acclaim Multi-Specialty Clinic had an open house ribbon cutting event, and I believe there were a handful of you that attended that. That is great work that under the leadership of Dr. Becker has really taken off well. And so we're looking forward to the work that they are doing as part of JPS. We did have a virtual September CEO town hall, and over 600 employees tuned into that. That gives them opportunity to hear as to what's going on here at the hospital and also out in the community. So again, well received. We just closed out our engagement survey, both for our employees and for our providers. I think what is to be noted is that last year we had about 71% of our employees take part in the survey, and this year we had 88%. And so that's good signs that we're recovering from the COVID. As far as physicians, last year we had around 37% of our physicians take part in the survey. This year it was close to 80%. So again, I think it really speaks to our staff wanting to be heard, and so it will give us opportunity to be able to understand what's important to our staff and to develop those action plans. And so we're looking forward to bringing that to you. JPS has been nominated for a number of DCEO Excellent in Healthcare Awards, and so we look forward. I'm sure there's going to be a number of those individuals who will actually win those awards, and so I'll bring that back to you. And then, Reverend Emerson, we did hear you as to the Veterans Day program that we've had in the past that we have put on hold for the last 2 or 3 years because of COVID. So we will be resuming an in-person Veterans Day recognition program on Friday, November 11th. And so that is all that I have to report.
Question, do we do anything, obviously the Veterans Day program is for staff and whatever else, do we do anything, do we know that kind of information for patients? Do we?
We have not in the past. We probably can get, I'm not sure how much of that is collected as
I don't
far
know,
as the
maybe a
demographics?
ribbon on the door or something, or a thank you, I don't know, just something I thought.
Yeah.
Do we have the speaker yet for that event?
There'll be a program that's going to be handed out, and I will reach out to
You have a speaker?
Let me know because
Okay.
I'm a good friend of a two-star general that was the last commander for the U.S. Army Japan.
So I know that we were looking for a speaker, so that's good to hear.
If you would send me the
Great.
information, we can reach out.
That's been a good program in the past. I'm glad to see us redoing it. Going back and doing that. It's fantastic.
Thank you, DT. Great suggestion.
Yeah.
Thank you. Now we'll have a report from medical executive staff. Dr. Miles, Publisher Miles.
Thank you, Mr. Chairman. I believe you're referring to the third quarter medical staff newsletter, which is all rule, thank you, which I've handed out to each of you just for your information. This has been distributed to all medical staff members, and it's being very well received, so we're going to try to keep it going on a quarterly basis. You will notice there are no delineation of privileges in your packet this month, which is something very new, but please be aware, we have not stopped working on delineation of privileges. We just had a gap between the MEC approving them and them getting into the board packet. So you'll continue to see more of those in the October packet. And again, we are hoping to close that project out in the first quarter of 2023 at the latest. The medical staff has been very busy with documentation. We have approved at the October meeting last Tuesday, we have approved brand new policies on how we conduct our peer review. We have a practitioner leave of absence policy, which is completely new to us. And finally, we have a completely new policy on physician and practitioner wellness. Those policies are currently residing with legal, where they're getting a final review before we publish them. We're also moving forward with a bylaws revision. If you recall, last year when you all approved the new version of the bylaws, they hadn't been revised for over 8 years. We are committed to looking at those on an annual basis going forward to keep them current, up to date, and reflective of our practice at JPS. Those revisions this year are relatively minor. The executive summary fits on one page, which is always a nice thing. They were approved by the Medical Executive Committee, so they will move forward to approval by the general medical staff. This year, we're doing something a little different. We're going to have our annual medical staff meeting jointly with our Medical Executive Committee in November. That is to promote transparency, collegiality, allow our medical staff to see the leadership in action. So that is where the bylaws will be up for a general medical staff vote, will be November 8th. Also at that time, we're going to have a number of reports, including Dr. Duncan will give a CEO report, I'll give a president's report. There'll be reports from each department to the general medical staff. So this is all something that has not been done previously. So we're pretty excited about moving forward with that. We're also looking at our holiday party, which is coming up in December, and I only mention it to you just to let you know that we're 100% focusing on recognition of our practitioners who do exemplary work in a very high resiliency state in this organization every day. So the staff party this year is going to be very much focused on recognizing a large group of physicians, top doctors, exemplary work awards, peer review strong work awards, nominations to like D Magazine. We've got a couple of physicians who are finalists in the D CEO Magazine awards. All of that is going to be rolled into a night of recognition for our physicians. And so there's a lot of excitement, a lot of buzz around that. We have a capacity of about 350 attendees, so we're thinking that we're going to cap out this year. So a lot of really nice things happening as we're bringing the year to a close. So nothing for approval, Mr. Chair, but thank you for the time.
Thank you, Dr. Miles. We'll move on to committee reports and action. DT, tell us how many cookies we get this month.
After the hearing that we had, none, so we adhere strictly to our wellness program. Thanks. Anyway, we met as committee, we met on September 22nd. And for the August financial report from the JPS hospital side, for the month of August, we had a positive operating margin for the hospital. In regard to the operating revenue, was above by 2%, and our operating expense were 9% higher than budget. We continue to see large unfavorable variance in operating expenses, primarily due to premium pay and contract labor. And I think this will continue throughout the year, so we're going to be putting a lot of effort from the operation into it. The month of August, the CMI, the case mix index and the length of stay was higher than budgeted. Admission were lower. Outpatient surgery, specialty clinics visit, and urgent care visit exceed our budget. And then the inpatient surgery, primary care visit, and emergency visit were lower than budget. From a JPS connection perspective for enrollment, in August we have 42,621. Out of that, 4,458 were new members, and we also termed 3,600 plus members also as well. From the acclaim perspective, we were favorable to the budget with lower than budgeted loss from operation. The operating revenue was above budget by 7%, and the operating expense were lower by 2% of the budget. Net patient service revenue was 11% above budget, and we also have 3% high in encounters. So as well, recruiting costs and continuing education reimbursement were high in August, but within budget for the last 11 months. On the consent agenda, we have 12 contracts presented for approval. And there's one thing that I want to congratulate our JPS is at the 21st Annual Asian Business Expo Award Luncheon. We received the Pandemic Healthcare Heroes and Diversity, Equity, and Inclusion Award. So congratulations to JPS family. That was our report.
Thank you, DT. Trent?
Good afternoon. Thank you, Mr. Chairman. We are going to give, as customary, we're going to talk more about the steering committee than we do about the planning committee, because the planning committee continues to meet in tandem with the finance committee. Dorothy has asked that we consider splitting those two back up again, because there are some more planning agenda items that she'd like us to look at. So we're going to be doing that in the future. We'll let you know what those dates are going to be and when that separation occurs. But probably moving on, what everybody's interest is the steering committee meeting updates. We did meet September 22nd. We are meeting again tomorrow. Highlights of the last meeting, we will be bringing to the board the issuance of the first tranche of debt for the new projects that will be in first quarter of 2023. So look forward to that. That's momentous for all of us. Including in that is going to be the Medical Home Southwest, the PEC, the MOB and parking garage, the Pavilion North expansion, the central utility plant, and supporting projects for those facilities. So it's going to be a big tranche of obligation that we're about to enter into, but obviously paving the way for us to get some of these pivotal projects started. Also, particularly of interest to the board is Will Murphy of K Strategies, who you all know has been assisting us with since the beginning of the bond project, specifically with community engagement and how we at JPS can increase our community engagement, specifically as it relates to the Medical Home Southwest. And one of the things that Will has asked the board to do, and you should have probably got an email on this, we're going to talk about it again tomorrow, but all board members are to consider potential participants in that engagement committee that can assist us with Medical Home Southwest. So they're putting that list of folks together now. So if each one of you would take inventory of your contacts and people that you think might be helpful in that role, it does need to be someone that resides or works within that Medical Home Southwest neighborhood. But if you haven't submitted names and you have some, it'd be a great idea to give Will a call and give him those names. I know he's going to be soliciting that via your email as well, so keep up with that. Probably next and most important thing is, we've all been working toward a closing of the Medical Home Southwest property, hopefully on the 9th of November of this year. That date there was some consternation associated with that date as late as yesterday, but happy to say that thanks to some support from our Commissioners Court and other folks that are very, very integral to JPS's success, we have been able to get through the City of Fort Worth's process to still close that property on time, which is a big deal, because what that allows is us to move forward with the groundbreaking. So December the 7th, if you don't have that on your calendar, put that on your calendar, because we're going to break ground on that facility and get that going. Around the campus, our Psych Emergency Center is already underway in terms of design with Beck Architecture, which you've approved that project. The parking garage with Beck Porter is also in progress right now, and the temporary parking design is in progress. So we have got a lot going on. Tomorrow will be another good meeting. One of the things that to look forward to is that we've asked John to give us a report on our financial impact of the operating dollars associated with the capital improvements. We started that at the last meeting, but we're going to go into a lot more detail over the next couple of meetings. We'll make sure the board has that information available. He's got some very good slides, I think, that are going to be helpful to us, and we're going to make some improvements to that. But the idea is to be able to look at the trajectory of capital expenditures relative to the amount of spend we have to have operationally, and make sure that we have planned for that and that we're looking for supplemental ways to do that. And part of John's job is to make sure that we have got not only ideas that help us cut costs associated with that deficit, but more importantly, to be able to introduce potential new income ideas to supplement our income and our revenue that help us hopefully avoid any delays concerning the capital and any delays we need when it comes to operationalizing those facilities. So that concludes my report, Mr. Chairman. Happy to answer any questions.
Trent, I want to thank you for your leadership sitting in many of these meetings that you have chaired. People often ask when dirt is going to start flying, and it's going to start flying very soon, and it's going to be flying very quickly, not only Southwest and whatever else, but here on the main campus. We are really going to begin to see the efforts of this bond issue, and many of those efforts are because of you and your steadfast leadership. So thank you for that. And it is really exciting. I'm not sure that the full board appreciates the magnitude of some of these kickoff projects and not just in dollar value, but in their importance, like the central utility plant, their importance for what the future of this facility will look like. It's an exciting time, and we appreciate that, and we look forward to those groundbreakings and that dirt flying and moving into new digs here soon enough. Thank you. Mr. Zimmerman, Zim, how about governance? I never succeeded there.
Thank you, Mr. Chairman. We reviewed the risk register for our current top 5 risks, as well as our top 5 risks from the previous meeting in June. Cybersecurity, 2 midnight rule compliance, and workplace violence were called out as the prevailing risks at this time. We looked at the fiscal 23 governance work plan. This year's work plan impacts JPS, Acclaim, and the foundation. One of the goals this year is to assess and report on impact that planned work plan activities have on delivery of high-quality, cost-effective healthcare services. Some of the planning audits we spoke about included interventional radiology, COVID-19 research, coding and billing, and substance use disorder treatment. And that's my report.
Thank you, sir. We'll move on to other matters requiring board discussion, updates, deliberations, actions, and/or approval. And the first up is Sharon Clark to consider ratification of agreement for the collection of taxes between Tarrant County Tax Assessor Collector, Tarrant County, and Tarrant County Hospital District.
Good afternoon. This is a ratification. There was some urgency as far as the timing. The county did need the return document by mid-September. So We did get officer approval on September 14th, but this is the agreement with the county that allows them to send one bill to the taxpayers and collect our portion of the approved tax rate from the property owners in Tarrant County. They have generously continued to waive the fee assessed, and this will take us through contract. This contract is through the collection of the 2024 taxes, so for the next few years.
Any questions or discussions? I'll seek a motion to approve.
Move to approve.
All right, Jim, a second. DT? Sorry, I didn't hear you, DT. We've got a motion and a second. All in favor, say aye.
Aye.
Any opposed? All right, the motion passes. Thank you.
Thank you.
Next item is consider approval of the resolution authorizing the amendment of the JPS pension plan. Dr. Duncan.
Yes, so a little bit of background here. In the past, we have had some of the acclaimed employed physicians serving in some of the JPS executive roles, and thus were enrolled in the JPS pension plan when we had the pension plan. Those individuals have since rolled out of those roles and are no longer eligible to continue to accrue those pension benefits. So this amendment solidifies those changes by amending the eligibility requirements section of the plan to state that pension accruals for physicians transferring out of executive roles will cease following the date of transfer.
Any questions or comments? All right, I need a motion to approve. DT, a second? Second. We'll go with Zim. All right, a motion, a second. All in favor? Any opposed? Thank you. Dr. Duncan, consider an approval of resolution authorizing the amendment to the Tarrant County Hospital District governmental excess benefit arrangement.
Just a reminder to the board, at the September board meeting, the board approved funding into the GIBA of up to $1 million for FY23. The current language in the GIBA document previously provided for a calculation of the funding amount to be determined based on the notion of lump sum distributions. This amended language provides for flexibility in determination of the funding amount and supports the board's decision at the last board meeting.
This item, I also believe that the special committee that Dorothy appointed last meeting, that those meetings have been set up. At least I've seen them on my calendar. Yes. So we'll begin getting further into the GIBA plan, but this will allow us to fulfill our responsibilities as we have them today. Need a motion to approve? DT in a second. All right, Reverend Emerson. Motion is second. All in favor, say aye. Aye. Any opposed? All right, motion passes. Thank you. Guidehouse in regards to
Jay's actually not here.
Oh.
Jay has since left Guidehouse.
Oh, okay.
But Guidehouse, and that's why I mentioned that Guidehouse is here. So Todd Harrington's here along with Emily.
Okay, welcome Guidehouse.
Again, first of all, welcome. Brian, do you want to, Dr. Becker, would you like to join up at the table? As we recalled, as we were setting the budget in FY, I believe it was 21, we had made the board had asked, and we had made the decision that we'd bring someone in to look at a claim after 5 years, to look at its operations, its governance, and to help the organization understand whether there were some opportunities for a claim to be structured in a different way, or whether there was opportunity to make some improvements on the current structure. There's been a lot of work done, and I just want to commend Dr. Becker for coming in after we had made this decision, and has already made just tremendous changes in a claim. And so you'll hear about some of those opportunities, but I've been impressed with Dr. Becker's ability to move as quickly as those opportunities were being identified. The engagement with Guidehouse has ended, and so we felt it was important to wrap it up with the board and allow the board to hear and to also ask any questions. So thank you for making the trip here, and thank you, Dr. Becker, for all that you've done to make Acclaim the great physician group that it is.
Thank you, Dr. Duncan. And I'll just start with an introduction. Dr. Duncan mentioned that Jay York has transitioned from Guidehouse. My name is Todd Hoisington. I'm a partner with the firm. I lead, actually, our physician enterprise services practice for the firm. And so I'll be helping with the presentation this afternoon, but also for continuity perspective, I've invited my colleague Emily Shields, who was a part of the work that was done here with Acclaim. So we'll be the ones speaking to you this afternoon. Appreciate the opportunity.
And
yeah. So the way we wanted to structure our conversation this afternoon was just to set a little bit of context of our focus within the JPS Health Network, specifically around Acclaim. We'll go into just an overview of what our partnership and the journey that you all have taken, what that is, and then get into some specific findings and solutions and relative to your current trajectory of where you are on the path. And then talk about some additional next steps in terms of transitioning to really driving enterprise value through Acclaim for the health system in total. We know that you all know your organization very well, but we thought it was important just to set some context with the way that you're structured, and specifically with Acclaim being an entity within the health network to be the employment vehicle of the physicians. Also wanting to call out very specifically that it's a very common structure to have, and we've called out the box of community health underneath the hospital departments. It's a very common structure within health systems to take advantage of what's referred to as provider-based billing activities. And that is in fact how you're structured. And the reason that's important is because the front office clerks, the medical assistants, the RNs that are in the practices that are supporting the physicians are actually rolling up to a payroll that's underneath the hospital, versus if Acclaim were an independent standalone medical group, that medical group would employ those roles. So that really holistically is your provider enterprise through Acclaim. It was already mentioned through one of your committee reports that while we're calling out the budgeted investments for Acclaim this year, but you have actually outperformed that, so that's very good news, hopefully attributed to a lot of the good work that's going on. So that's the context and the focus of our work with the Guidehouse and the work that we've done with Dr. Becker is specifically within the Acclaim. I'm going to let Emily talk specifically about the work, given that she was very directly involved, and how that's played out, and then we'll kind of wrap up with some next steps for you all and entertain any questions.
thank you, Todd. And thank you, everyone, for having us here today to speak about a lot of the great work. We actually began this journey in April of 2021, so it did come before Dr. Becker was here, and completely echo your comments, Dr. Duncan, that we've been able to make a ton of progress with you, Dr. Becker, with you jumping in. But we wanted to start by talking about the overall journey of our partnership, in starting with the assessment that we mentioned. We took a really comprehensive approach. We did site visits, we did interviews, we did a lot of data analytics to come up with what are the challenges with Acclaim, both within the walls of Acclaim, as well as how other entities such as community health connect to Acclaim. And then that immediately fed into two parallel tracks, the operating model redesign as well as the compensation model. We know that this board has had a report out on those. We do want to do more of a deep dive into that operating model redesign work, but we have some of the focus areas at the bottom here of what has been accomplished across a claim since we started 18 months ago. Of course, that new compensation plan. There's also been increased productivity in looking at work RVUs. As it was mentioned in the beginning of this meeting, there's increased visits. We also took a look at the infrastructure of the physician leadership. We looked at accountabilities, workflows, and even there's been a recent work group around revenue cycle. So a lot of progress in the last 18 months, and this is just at a glance what that's looked like. In the next slide, we'll talk about more of a detail of what we actually assessed. There were really 4 different groups of analyses that we did, one around revenue strategy with productivity, access, and revenue cycle. There's also the physician compensation plan, of course, but then the operating model and organizational structure that feeds into that. One of the things that we focus quite a bit on is the physician leadership structure. It's really critical to have physician leaders to drive change and to be physician-led. But what is the right type and structure of those leadership responsibilities? And then, of course, operating areas. We met individually with each of the groups here across finance and analytics. And that was how we structured that. And the benefits, as we mentioned, is that we're outperforming the budget currently. The $43 million is more 31 projected end of year. So a lot of enhancements, not only within the Guidehouse engagement, but outside of it as well. We have a great plan to address that operating model structure. And then the rollout of compensation models compensation models is not a cost-cutting strategy. It's a way to align your physicians with the goals of the organization. So whether that's, the quality of care, productivity, which aligns to access. And so all of those things are either implemented or underway.
Emily, can I ask you a question about that?
Absolutely.
When you're looking at the opportunities, on the left-hand column, the opportunities, what is our current vacancy rate for positions in a claim? Does anybody know roughly?
Yeah.
What is it?
We have 31 positions that are open. 20 of those are being actively recruited, and we're working on the subsequent 11. That includes APPs and physicians. Right now, we stand at about 490 clinicians. So obviously, we're looking at 10% or less. Our 2-year turnover rate right now is averaging just under 10%, with 10% kind of being national benchmark.
So the reason I asked that question is because that's historically been a challenge for us, especially over the last 2 years. And maybe it's just here and I'm not seeing it, but among the opportunities that you're assessing is embedded somehow recruitment and the ability to try and get these positions filled and what it's going to take to make that happen?
So we had a recruitment assessment within the work that we did. We looked at the workflows, for example, even once you get a physician, how can we onboard them effectively so that they have a great experience and they come here. But outside of that, Dr. Becker, I believe that last week we chatted, there's even more broader initiatives around that as well. But would you like to speak to that?
So we adopted several things that related to process flow and reducing the cycle time of what we could do to get people more effectively into the organization. I think we probably cut about 14 days off of that, to be honest, from where we were when I started. We have changed the approach from a recruiting standpoint to both increase the breadth of where we're going from a diversity perspective. So we significantly broadened the potential candidate pool, and the approach and content that we're pursuing in that regard is modeled on, at a very low level, what you might do if you're developing a messaging journey and you had Salesforce. So we're working pretty iteratively in that context. We do have 3 big challenges. We have a small recruiting team, and physician recruiting is different than recruiting in the rest of the organization. So we have them pretty active, and we have them working about, as you just heard, right now we have them working at max 10 to 15 positions simultaneously because of prospecting, sourcing, reviewing, and getting alignment there. The second piece is there are individuals who are looking for some specific features of the job in specific geographies of the country. So we're having to make certain we balance that with the first piece, which is broadening the pool where we go. The third piece is actually the comp piece. And so having a different comp model makes it much easier for us to make an offer that isn't going to be top of market, but certainly appears competitive, even in the context of where we're at in the local area.
Thanks. It's been a long time, but we have had in the past assistance from outside contractors when it comes specifically to recruiting. I don't know if that's a legitimate model or not, but we've just continued to hover around that 10% vacancy. And as we look specifically at the capital projects that are coming online and the number of physicians we're going to have to staff the hospital, I just wanted to hear what our thoughts were and how we plan it, because I know compensation modeling is a part of that. It's always been a part of that. It's not exclusive, certainly, but to the extent that we can continue to hear from a claim about opportunities to improve our recruitment, whether it's compensation, whether it's work environment, panels, hours, I don't know. But I hope those opportunities continue to come to the board so that we can hear what we can do to make that better. Didn't mean to chase a rabbit, but I just wanted to make sure that that opportunities list included that effort.
That's important. I would just add one point to that is oftentimes today what physicians are looking for when they're evaluating employment opportunities is what is the infrastructure that is around them to help support them in their practice to make it more efficient and easy for them to come in to see patients, because that's really why they went into medicine, is to see patients. And one of the advantages of being part of a system is to have more of that infrastructure around you versus back in the day of being more an independent and starting from scratch. So I think it's really important to focus on the infrastructure that's around them, which is inclusive of not just the technology components, but really what's the care model approach, what's the team approach of how you're organizing and helping them with that, with their patients.
The only other thing I would add as it relates to the growth and the facilities is that when we were reviewing the administrative component of physicians, creating the right infrastructure so that they can spend the max amount of time taking care of patients and less administrative time. Not only does that help improve access, but you may not have additional bodies, but you have more patient-facing time out of those providers, and they're able to function at their max level.
Yeah, great. Thank you.
Any other questions before a deep dive into the operating model? One more level of detail with this work. We wanted to highlight, one, all of the dedication that the Acclaim leadership and staff had during the operating model project. We had 3, 4, 5 working sessions with every department across different clinical departments, as well as revenue cycle, finance, to really understand what is the structure, what are the challenges, the roles and responsibilities across those different departments, and how they intersect. We heard a lot when we were looking at workflows that here's where our piece starts and it connects to this department. And so understanding the right warm handoffs. From there, we worked with Dr. Becker as well as the leadership of Acclaim to prioritize a number of initiatives to get Acclaim the lowest hanging, highest impact initiatives. And we set into design sessions and as well as implementation, some of which were phased. But we have some key outcomes here on the right side of the slide. particularly around that medical leadership, as we were just talking about, having the right administrative structure. Well, part of that comes from designing the roles and responsibilities of each physician. We had a lot of physician leaders that had more administrative support functions, or even doing more performance management as opposed to what is the most efficient and effective way of managing physicians. We developed a job description as well as some ways to measure when is the right time to have a physician leader, and there's been some right sizing of that physician leadership structure, not only from a decrease in allowing more hours to see patients, but as well as helping them to be more effective in those roles. We also looked at the business analytics function. We had a group of people mostly focusing on quality incentives. We redesigned where the accountabilities were for that group into the quality committee within a claim to ensure even more efficacy with those conversations. We took a look at the finance capabilities as we were in conversations with the leadership team. That group was mostly doing accounting and wasn't really looking into forecasting, and so we looked at how to expand the capabilities of that team. And then finally, we documented the core workflows as well as suggestions for future state where we didn't have a direct influence in that implementation across various departments. So a ton of work, really appreciative of how engaged everyone has been. We met with a number of physicians a lot of times, so it was a great experience.
Deeper to first understand what those entail. Is that to address collection, address net collection, less appeal, or documentation, or anything there?
Yeah, great question. So in its current state, there was a lot of focus around payroll, accounts receivable, how to manage that, but we weren't using finance to more proactively manage the business because frankly, we didn't have the capabilities in-house. And Dr. Becker, I believe that you've completed the expansion of that team to even be able to take it that step further so that we can make more decisions based on what's to come further out, projecting volumes, and then also being able to optimize those. So anything that you would add there, Brian?
I think, first of all, thank you, Emily. DT, to your question, we needed to move from how we have historically been, which was somewhat of a big step back. Medical groups focus on finance and what comes in the door is obviously very different than what a hospital does. Not only are you focused on far more of the individual dollar, but also the diversity in your revenue streams becomes very, very critical as you're both looking at your present book of business and attempting to figure out how you're going to manage in future state. Whether it's a shift in contracts, whether it's the addition of a new payer, and or figuring out how you're going to better manage a population with the other types of revenue, quality, shared savings, et cetera. Our capabilities were very lean and primarily focused in that area on how we were just getting some money in the door for what we were doing. And are we bad with revenue cycle? We're solid, and it allows us to collect a reasonable amount in context to what we think we should be collecting. But it's vague. We needed to take a step back and look at, in this context, what's influencing our ability to make certain for the great care that we deliver that we get something in the door that's appropriate for that care. That started with having a better understanding on a contractual level what we were supposed to be receiving, making certain we were following up on that. Rev cycle, not just doing their work, but actually pushing AR. It also was making an assessment when we were bringing in new populations of patients or different patients from different payer groups, what we anticipated in terms of utilization, how we then could start be looking at what we should be bringing in for the work that we're delivering, and the third one I'll mention is getting a better handle on the quality and value-based care revenue that we had access to, and identifying how to maximize the appropriate care and the ability to appropriately document to get that revenue into the organization as well. Those are three big areas in addition to forecasting volumes. Last point I'll make, you may recall I commented we had projected out with the shifts in our operations during the last fiscal year what the impact was going to be on the practice, and just trying to get a gauge on that so we knew how to adjust our expenses and what we were pursuing, knowing that we had that as a consideration. Those were important for us to have to be a better functioning medical group.
I was a little bit more curious about inline value-based care. You know, when I looked at some of the stuff in the index, appendix, I've seen AR days lower, but collection is actually below average, national average. And then the percentage of patient pay is also lower. Right? But then I don't see, and the thing I'm questioning is that, do you go deep enough into, like for instance, if somebody admitted under observation, I mean under inpatient type thing, and there's an army of people on the MA side, he's going to challenge that and say it should be observation. And then we may code it as a concurrent review as outpatient observation, but then Epic or some bridge routine may still shoot out as inpatient, and we try to collect on DRG and they still pay on this side. What do we do that to enhance? What can the clinical side or the administration side arm the finance committee, finance team to be able to appeal those process and stuff like that? So I'm not sure if you guys cover down that path, because they're going to go after 2 or 3 days admission. They're not going to go after 5 because you need to provide those care. They're not going to go after that, but they're going to go for the shorter one. And that's where I'm trying to see.
If I may, in that regard, it's probably not appropriate in this presentation, but I think knowing the work that Colin's done and some of the things that we're working there to the exact specific scenario you're describing, there may be an opportunity to discuss that at some other point in time. And I think the work that he's pursued specifically addresses some of your concerns with our clinicians.
I'm just trying to understand, because it's put on here, so I would like to see what is your observation behind the scene to give us some kind of roadmap type thing. That was what my question is, not to go more specific on the process itself, but does it actually, is that part of the thing that you see that we should be paying attention to, or is it just on the surface and then we still have to go do a deeper dive?
Making a distinction between finance and revenue cycle is important in this regard. So when we were assessing finance, we were looking at the true business support functional model within a claim. But then also there's revenue cycle, which is billing for services rendered. There's collecting, having the right payer contract rates. During our assessment, we did address the revenue cycle function. We had a team that looked into that, and with the controllable elements of the revenue cycle, to your point, days in AR, it was pretty well managed. What we focused on in the beginning was, do we have the right functions with what the finance team is doing from an analytics perspective? Going forward, there's how we are actually performing in the revenue cycle and what are we billing, how are we collecting? And that's a current initiative that is underway. And to your point, there's more work being done. But just distinguishing between the financial functional model of the support services within a claim and then the true revenue cycle billing and collections performance is separate from in the engagement that we did.
I think within that context, what you were describing, what I was hearing is even a different section within revenue cycle, which is really more around clinical documentation and how that plays out, and then how that translates to what your bills are, not only on the hospital side, but on the physician side as well. And clinical documentation is an important initiative that many systems are taking a look at, because there's often significant dollar opportunities related to that from just assuring that your documentation is supporting the billing that you're doing.
Great discussion. Any other questions? If not, I will pass it back over to Todd.
Sure, thank you. So just to round this out a little bit, the journey that you started is a great one. We pulled from your 2021 strategic plan the imperatives that you identified, starting with culture of excellence, looking at care models that are organized around delivering care in the future, and then creating that ability to really help be a service to your community. And so what's the connection point? The connection point is, the circles that we're describing here, the concentric circles, is it's the right place to start looking at the infrastructure of your provider enterprise, and kind of the key metric or outcome that organizations start with is that investment per provider. You think about the investment dollars a few slides back, where the 40-some million budgeted for a claim. That says, are we optimizing this asset in the right way? You move beyond that and now organize yourself and shift from a lens of thinking of the investment in the provider enterprise as a loss leader to more of how is this physician enterprise helping our system create and generate value. And value not only from the health system perspective, so looking at health system margin, what are those downstream implications of patients that are able to access not just your physicians but your services within the hospital and the ancillary services, but also beyond that, enterprise value of thinking about overall growth. How is the system accommodating growth? How are you looking at your market share in the position? And then ultimately, what is the value or community impact? And we know that you have ways that you're measuring community impact. I think what that really does is allow you to kind of transition to how we would kind of understand sort of the next steps of your journey within a claim, and kind of this move towards managing your populations. And it really starts with on the community access side, so meeting the needs of the patients in the community that you serve, starting with those that are within the tax base of your district, making sure that they have the right access to the right provider at the right time. And then really transitioning to, are we facilitating a way to get better access and more convenient access through a virtual care delivery? We noticed that you actually did call that out as one of your objectives within the strategic plan. It's the right focus. Many organizations are moving there. COVID sort of precipitated a quick acceleration and adoption of that. I think since the days post, we've seen sort of sort of the downward slope of that. But many organizations, and it sounds like you all are wrestling through this, what is that right mix going forward? And it's inclusive of your care models, of how you think about that. We see a lot of organizations that are moving towards an APP, advanced practice provider-led sort of virtual care model that facilitates better access, quicker access into the system, as an example. Looking at how you're utilizing your medical resources. We talked a little bit about that when you were asking about recruitment and retention of your providers. That's critically important so that it can actually become a recruitment tool. And I don't know if this is something that you're experiencing, Dr. Becker, but one of the things that we do see across the country is beyond just true attrition of physicians actually leaving, this notion of fractional quitting. So people reducing their amount of time that they're seeing patients in the clinic, so reducing their clinical FTE, which is the equivalent of, if you add all of that up, that can be the equivalent of, multiple clinical FTEs. And so, again, the focus on the resources that you're offering to your physicians and other clinicians is extremely important. And then finally, around the population management, so thinking about moving into the value-based care environment, but even the tax dollars that you do receive as an organization as part of your revenue stream, it could be equivalent in terms of, that's a defined amount of dollars that comes in, and how are we optimizing that through efficient structure of the care models, and think of it as sort of along the lines of a PM type approach. So that's really where we would see your next steps opportunities. You've started with the foundational aspects, putting the building blocks into place, and I believe you're starting to see the fruits of those efforts, and then really organize yourself to continue that push along that journey. Yes, sir. To entertain any other questions from the board?
I was waiting for DT to say something.
I'm just afraid to go deeper, and it's out of scope, so that's why I'm careful not to ask the question that's out of scope at this point.
No. Well, I am, personally, as spending a lot of time with Dr. Becker and what a claim has done, and I can just assure you that there is no grass growing under Dr. Becker's feet. He moves quickly and strategically, and I've been very impressed with it. I appreciate the summary of y'all's efforts and Jay's efforts with us. My question to Dr. Becker, is there anything else that you need out of this? I mean, from our meetings, it seems like you're on the road to get there. So,
I first of all appreciate y'all hearing it, and glad that, and hope there's a comfort level that questions you may have had around what your initial engagement was, certainly before I landed here, have been addressed in a manner that you all are comfortable with. And then second, the only thing I would add, and thank you to those folks who were on the team that you're on, and Emily in particular, for the work, is that I do think, A, it was very helpful, and as long as you're comfortable with these as directionally where we should go, we're moving this direction across the board. And the biggest guidance that I need from you all is, if you're not comfortable, we want to make certain to redirect in a manner that you are.
Sure. DT, why don't you move that microphone just a little bit closer to you so we can understand what you're saying?
Yes, sir. Somebody already turned it on for me. I think my question is around, because as we look at transforming healthcare, do we have enough here to help us with physician compensation, right? Because it goes hand in hand as we move things around. I don't have a clear example, but I just can throw out, like, let's say if we ask our emergency physician, try to reduce ED visit to prevent the next one, or, for preventive and all sort of things. Do we have enough here to offset? Because if they don't admit and they don't perform certain tests, it's going to be less, because you eat what you kill, on top of for I guess standby coverage type thing, right? So as we transform them and things that they can go into outpatient versus inpatient, 72-hour admission, all sort of things, as they prevent these things, it will hurt their pocketbook. And we kind of in a strange relationship, because for fee for service, we bill for what we charge, but for our connection patient, we are the payer ourselves. And how do we balance that? And then do we have enough here to say, what is a sense of what's the MRR look like, right? We don't have to be exact, but at least we know where we land. If we are at 92 or 95, there's no way we're going to enter into an agreement for full risk. Because full risk, you only get 80 82% or 85% of what the MA plan will give you. And you're going to take the loss the day one when you enter into that relationship. So I still don't have that sense where we are to see how much work or effort that we need to prep. And it's become more and more critical as we build the hospital. There's a lot of, work around, a lot of contingency plan that we have to put in place, and that's kind of very scary to look at, right? And so as we go through the compensation, do we lay out the groundwork? Do we know what we look like? What we need to be doing now so that we can prepare for that journey?
Sure.
Or if we do something and we're off base, it's hard to retract.
I would say that I would start with the fact that you've defined a compensation model is excellent because it gives you a foundation to start with. And so now it's really about how you define the elements of that model, particularly the approach to incentives. And I think that gives you the opportunity to align those incentives to the goals of the health system. And, most health systems are wrestling with exactly what you just described, which is sort of that transition from a volume-driven, fee-for-service-driven model to that journey more towards the value-based approach.
Right.
And really, the challenge is kind of having one foot in each of those canoes, and what does that journey and transition look like? And I think by having a defined compensation plan at least gives you some footing to start with from there, because, if you've got certain specialties that are still more inclined towards the fee-for-service approach, you can structure incentives in that way, but also start to build in some elements that enable you to incentivize behaviors and outcomes and things that you're looking for from that value journey.
Right. It's easy from a textbook and theory perspective.
Yes.
But for us, it's a little bit more complex because we are one of that has one of the best family medicine program. So if you look at RVU and all that stuff to compensate them, we may inadvertently messed up our attractive because of OB, because we train them to go to rural area, and if we don't get they don't get compensated for OB work, that's going to degrade our program also as well. So that's what. But then we're not engaged. We cannot be engaged in clinical outcome. In practice, but we'd like to understand a little bit more of the destination so that we can set the right policy or plan the right support. And it's kind of like, I'd like to go beyond trust us. I'd like to go a little bit more disciplined in that regard as we go through the process.
Thank you, DT. Any other questions? Thank you all for your report.
Thank you.
All right, we'll move down to the consent agenda. There's 17 items on the consent agenda, and everybody has them in front of you. I'm not certainly going to read them all, but if there are any consent agenda items that anybody would like further discussion on or would like removed, speak now or forever hold your peace. And since no one's speaking, I will take a motion to approve the consent agenda. Okay.
On this is a consent agenda or not is, I guess, the last two items.
L and M?
Yes.
Yes. Is that on the consent, or are we going to approve one by one?
Oh. Yeah. Planning, yeah, so the planning and claim items are part of the consent, yeah. So the lettering is off in the indentions there, but it is the finance items, A through M, planning item A, and a claim item A and B is the consent agenda.
We did not, for Finance Committee, we did not see those two items, so that's why I want to get clarification.
On which one?
For the for the last two items on the agenda.
For the acclaim. Okay.
Yeah, acclaim.
I think Daphne has a clarification.
Right.
Sure. Ed, traditionally, the Acclaim Executive Committee has approved its contracts, and then they roll forward to the board on consent agenda. There has been some discussions about how those contracts will be reviewed going forward, but this is typical and customary for how these items have been approved in the past.
Right. I think I can understand, and the dollar amount is there for the next to the last item regarding to the Optum 360. The last one regard to the WellMed network and all that stuff. It's hard as a chair of finance when I don't see the dollar amount attached to it to see what are we approving. Just rough estimate or whatever that is. It's not on there. And then the second thing is, I still remember, I think we still don't have, we may have an agreement in principle, but we still don't have a written agreement from UHC, United Healthcare, for the administration of the COVID vaccine. And for me to approve another division within United Healthcare is rewarding for bad behavior without knowing what the dollar amount impact is. So that's just my comment, observation and comment. But I understand.
The amount is on there.
No, A is on there for Optum, but the next one, the WellMed one, is not on there.
You're just talking about item B.
Yes. Not item A.
May I make a point?
Sure. Go ahead, Dr. Weber.
The WellMed contract is actually a pure revenue contract. It is providing us revenue as an organization to assist and support in aspects of appropriate care for their patients. And I can provide you with the dollar item that they will be providing in that context.
And the second thing is, I know Acclaim that time needs to be independent a little bit from contracting, but the care coordination, I don't know, because they're going to do some gap closing and all that stuff. How's that going to coordinate with Joy and her team from the care management piece and all that stuff also as well?
The revenue contract is designed to provide support for us hiring those individuals. Mm-hmm. So those individuals would be part of our organization, part of JPS, that would be involved with providing that. So that's how that's coordinated internally.
Okay. And do you know what's the ballpark figure that would be for this contract?
Yes. It's approximately $600,000.
$600,000? Yes. Okay. It's not material or something? Okay. That's fine. Thanks.
Okay. You're good to go?
Yeah, I'm good to go.
Okay. All right, we got that cleared up. So we're taking the finance agenda, consent agenda, which includes the items under finance, planning, and acclaim. Do you have a motion to approve?
Move for approval.
Okay, I got Trent first. DT, you want the second?
Yes, sir.
DT with the second. All in favor?
Aye.
Any opposed? Okay, motion passes.
No report this month.
No report. Okay, we will, at 2:27, adjourn to closed session. Thank you. We will reopen the Board of Managers meeting at 3:02.
It seems really loud.
With that, we have privileges. I need a motion to approve. Dr. Simmons, second by Zim. All in favor? Any opposed? All right, that motion carries. With no further business, we stand adjourned. Thank you.